Okay. Hi, Tracy. Hi, Wen. Welcome, welcome. Thank you for joining us. I'm going to give the rest of the registered participants a couple minutes to join, then we'll start on the hour as usual.
Celeste, do you want to throw up the first slide so they have the
I
QR
will.
code?
Yes. Hang on one second.
Thank you. Hi, Anne. I remembered this time. Hi, Lisa. I'm going to go ahead for those who have already joined and put a link to the pre-session survey questionnaire, just those quick 5 questions into the chat box for you all. So if you could take a minute to complete that. And like I said, we're going to wait about 2 more minutes. We'll start right at 4 p.m. Eastern. And then the QR code's also on the screen too, if you folks prefer to do it on your phone. But if you're at a computer and you would like to click on the link, it is in the chat box. Tracy, and we've got Anne, Miss Anne, and we have Lynn, and we've got Elisa. Hi, Elisa. Welcome back. All familiar faces. And again, if you guys can just take 2 or 3 minutes, or not even that long, it'll take you just a couple minutes to answer the pre-session survey questionnaire while we wait for the rest of the attendees to join us. That would be much appreciated. And I put that link again in the chat box. It's also QR codes on the screen if you have a smartphone, whichever you prefer. It's the same questionnaire. Hi, Sheila. Welcome. Welcome, welcome. The pre-session questionnaires in the chat box, Sheila, if you could take a minute to complete that while we wait for the top of the hour and the rest of the participants to join us, that would be great. Excuse me. Just as a reminder to everybody, this should be pretty common knowledge now. We do have everything muted for participants. So if you have any questions or comments during the session at any point, feel free to use the chat box. Myself or Elaine, who's on the call, or Mark and Celeste, whoever's not doing the actual training, will answer the chat box. There you go. Sorry about that, guys. The pretest
No worries.
in the chat box. I was inadvertently just showing it to the host. So thank you, Sheila. I did that last week too. So everyone should be able to see the link to the pretest questionnaire in the chat box now. Apologies. And I think we can go ahead and get started, Celeste. And then Elaine, you and I or Mark can tackle the chat box as folks have questions.
Volunteer to do the chat box. And with that, I will go ahead and introduce myself once again. I'm Mark Harvey. I am part of Rogue Behavior Analysis, which is a group that's working with individuals with intellectual and developmental disabilities. I've been working in the field with IDD for about 35 years. And through that, I started working with NADD about 4 years ago, and really excited about working with them and working with individuals who have IDD and also mental health conditions. So with that, I'll turn it over to Celeste. She's going to be your guide for the day.
Well, not the whole day, but hi, everybody. Glad you're here. I wish I could see all of your faces and be able to interact with you in person, because that's my favorite way to do this. So I'm Celeste Harvey, and I'm an associate professor at the Chicago School in Dallas. I'm a Floridian by birth, so I figure you're my people, most of you on this call. So I needed to just do a couple of little housekeeping things. First of all, just to tell you to make sure you do the pre-training test, even if you just showed up a little bit late. There's a QR code right here on the screen, but there's also a link in the chat. And then as soon as you've completed that, I don't know, you could either send a little note through the chat, or we'll just put you on the honor system and keep moving on. So it's important for me to note that this project is funded by the Florida Developmental Disabilities Council and developed in partnership with NADD, the National Association for the Dually Diagnosed. I highly recommend joining NADD so you can keep in contact with publications and trainings and other resources that may be helpful to you, whatever it is that you do in life. If you love people and care about people with intellectual and or developmental disabilities who may have a secondary mental health diagnosis, it's just been a wonderful group to work with. I've worked with NADD now for, I think, about 5 years on various projects. So I want you to know that this project is supported by the FDDC and NADD, and that the information I'm going to present to you is information and content that we developed for NADD, and it's not necessarily in any way representative of NADD's perspectives or FDDC. It's content that we put together based on state of the art and the evidence available. So feel free to use that chat button. That's how we kind of get the human touch engagement here as we're talking about some of these concepts and ideas. I have worked with people with IDD and co-occurring mental health conditions for somewhere around 35 years. And I can tell you that there are always surprises, but there's always something we can do to help plan to prevent problems from happening in the first place and better ways to intervene. So that's really what we're about doing today, is talking about that. So I want you to know that the definitions and eligibility requirements, the age ranges, and states and service systems will vary. Just note that if you have questions about how to access supports or services, you might drop us a line and ask if we can offer support, or just, let us know if there's something we can help you to find. And then look at the resource list we're going to give at the end, and you can always talk to a disability support contact, at the state or local level for more information. So today we're going to talk about what a behavioral and or mental health crisis looks like. And the slash is there because often we'll see behavior indicative of a mental health crisis. And that's how we know, right? So we'll talk about that, what it looks like if you're watching, and how to document a behavioral or mental health crisis. I worked with a psychologist back in the early 90s, and he used to say, if it didn't get written, it didn't happen. And what that really means, I think, is that we need to be clear about documenting what we observe, what it looks like, what the events around the person might include, so we can put that in a note so we know what to look for. We know how to potentially intervene earlier, or even remove potential stressors from a person's environment if that's what the team determines is best. We will talk about implementing de-escalation strategies as needed, some strategies for intervention during crisis that are trauma-informed to help minimize harm, and some crisis-related resources in Florida. So although today I don't believe you have these slides yet, you will be receiving them from Dr. McGill. She'll be sending them over so everybody will have access, including links to some of the resources we're going to talk about today. So what we're going to talk about first, what a behavioral mental health crisis looks like, how to document, strategies for intervention during crisis, and then some specific Florida-based crisis resources. So number one, the description. We're going to talk to you about how to describe what a behavioral or mental health crisis looks like. And if any of you out there have worked with multiple people or supported multiple people who have a disability and maybe exhibit some behavioral changes that could be consistent with a developing crisis or an actual crisis, then it can look different from person to person. And I think even if we think about the ways we behave when we're under stress or duress, we might behave in different ways than our peer, a family member, or a friend, which just makes sense. Everybody copes in different ways. So during a crisis, it's important to describe exactly what you're seeing and making sure that we are aware of signs of the impending crisis, which I know we talked about in modules 1 and 2, and then how to respond correctly and efficiently and appropriately to try to de-escalate as early as possible. Because assessment and de-escalation are the vital first steps. The crisis response is going to follow. So as a crisis is beginning to unfold, we want to be able to assess the situation and figure out if there is anything we can do to de-escalate the situation. So the way people experience crises vary from person to person. There are so many factors that go into creating the thoughts, perceptions, and feelings of anybody that we know. We want to make sure someone who knows the person and their background is available and either provide some documentation or some narrative descriptions that we can also use and build a good plan for the person. During a crisis, we know that it may be difficult for a person to function or conduct regular activities because they're overwhelmed by symptoms and stress. Most of you have probably heard of fight or flight, right? In fact, there's an area in the brain called the hypothalamus, and it's associated with the 4 F's: fighting, feeding, fleeing, and mating. That's kind of a joke that we use in neuroscience. But truly, there are folks who will sometimes react in a way that appears aggressive. They may strike out at someone else or destroy something. There are some who may freeze and be completely unable to communicate or indicate in a way that we can respond to that they're having a hard time, right? And then there's fleeing, and there are some who will even try to leave the scene of a stressful situation, which can certainly be a crisis. We know that if somebody elopes or leaves an area where there are people to keep them safe, we may be concerned about other people victimizing them or harming them, or even having a bad encounter with someone who's trying to de-escalate but does not know what is needed. So when we are describing the crisis, we start doing an assessment, and then we look at the measures to de-escalate. Then the actual interventions and strategies are developed to respond to the crisis. And usually what we think about here is that the best predictor of future behavior is past behavior. And that doesn't just relate to the person experiencing a crisis, it's for us. If we know that in the past, approaching somebody and putting hands on them, even if it's sometimes a touch on the arm or the shoulder, sometimes it's a tone of voice. If that is something that in the past has led to the person escalating and perhaps interpreting what we think is well-intended help as, a position of stressing or distressing them, if they escalated, we might say, we're going to stand back a little further in the future, right? So we need to do those assessments based on the information we have, the documentation that we have, to be able to develop a plan going forward. Okay, so for those of you who are in the last module, I don't know, who was in the last module? Anybody here? Thinking about what we talked about in that last module on pre-crisis behaviors, what are some examples of things that someone supporting a person in crisis should consider? Okay, so what do you think? Is it A, triggers identified and tips for managing triggers worksheet? Is it B, past trauma experiences documented in their biographical timeline? Do you think it's C, strategies to support the person as outlined in their individual crisis plan or behavior support plan? Do you think it's only B and C, or all of the above? So triggers, past trauma experiences, strategies to support the person, only A and B, or all of the above. I'd love to see y'all enter some thoughts in the chat on this. And then Mark will scan through to see if we
Getting ease and ease and more ease.
So the E's have it, all of the above. It's very important for us to try to make a note of the specific conditions. So sometimes we call these antecedents in behavior analysis. You can use the word trigger. if that's something that's more comfortable, but what kinds of events occurred before the behavior of interest that indicated a threat or a possible crisis. We want to know about past trauma experiences from a person's history. If we are aware that a person had an encounter in a doctor's office that was, maybe they were given a shot and the injection hurt, right? And then maybe their arm felt sore for a few days. There was an aggressive episode in the doctor's office. If we know about that, then maybe we know in the future when we go to the doctor's office, we have a comfort object available. So maybe it's having a lovey, like a teddy bear or something. Mark and I have a daughter who's 19 who does not do well with blood draws, and she has a history of like turning sheet white and passing out. Headphones in the ears, simple, fun music going on, and do not look at the blood. I mean, that's just a way that we would try to like get her to work through what could otherwise be a really tough situation. They really don't want you to pass out when you're giving vials and vials of blood. So if that's a traumatic experience, we try to make a plan for how to manage it better and early. And then strategies to support the person from their crisis plan or behavior support plan. Again, this comes from knowing the person for a period of time, being able to get good data and working on following the plan accordingly. So documenting. This is like hashtag stuff behavior analysts say. And in fact, probably other medical professionals and people who support a person who may have an intellectual or developmental disability. Write it down. Like, what exactly happened? When did you notice a change in the person's status? And it's so important to be able to do that. So what you're going to write down. And honestly, if you don't have a special sheet that you document this on, you can get a notepad, maybe keeping a journal is really helpful. If the individual, him or herself or themselves, is able to use a notebook and journal about their own experiences, that can be so valuable. Teaching people to journal is a wonderful tool for folks who have that skill set and that we could foster more independence. But if they're not able to do that, if they're not able to document it themselves, then what we could do is write down like what was happening immediately before the incident. What exactly did the behavior or incident look like? So a lot of times we will find we use terms like anxiety or agitation or distress. And I think colloquially we know what that means, right? If you think about it, you kind of get a picture of what that means. But what we're really interested in, especially, from a behavior analyst lens, is what does it actually look like? So if you see a person who starts to body rock more, or maybe they're chewing on their nails and ripping them off, or some other sign that there's a developing crisis, writing those things down is so important because we'll be able to intervene at the appropriate level and provide support before it's too late, and hopefully we can avoid it from happening. Writing down how many times concerning behaviors occurred. In my line of work and Mark's line of work, I think we're always trying to minimize any need for someone to call 911 or place someone in a hospital setting, et cetera, for evaluation. There are often signs before something does go wrong. Sometimes these things will look like they come out of the blue, right? I once worked in Miami with all adults with IDD diagnoses, and I looked out in the parking lot to see one of our, grown men jumping up and down on the hood of a staff member's car. And it was like, that's a crisis. What happened before that? He had an altercation with a peer. The peer punched him. So he went out and jumped up and down on a staff member's car. If I had had a little bit of a warning about that other altercation from someone else, maybe I could have stopped him and talked to him and offered support. But at that point, it's like we have to stand there, be ready to direct him to get off the hood of the car, contact the insurance companies to come over and assess the damage, and we go from there. But how many times these things happen, that's important. Like if you're looking at repeated instances, that's important to document. The duration of the behaviors or incidents. So what time did things start? What time did they end? Noting who was present at the time. And I like to think about controlling the scene to some extent if you can. You can't always move the person who's acting out. It's just not going to be easy, especially in public, which is where I've spent most of the time, working with folks. But you might be able to direct people away like, oh, can we just have a little space here? And do you mind moving along? To try to provide a little bit of privacy and respect for the individual. And then what elements of the individual's crisis plan were initiated? So we want to know if we're doing things correctly. Are we able to determine if there is a medical issue for the person? Are there other possible things that have happened around that person that might indicate a possible impending crisis so we could react better in the future? So there's so much to consider here, and you're not always going to know exactly what to do in the moment of a crisis, but it's going to involve, I think, minimizing a lot of looky-loos coming in, trying to get some space if you can, trying to reinitiate and stabilize uh, really the whole event with the person. And so there are just a few things to look at. And as you do, you can write those things down and be prepared to revise a crisis plan if needed. So consideration as crisis behaviors begin. So before a serious episode, there are often precursors or warning signs. This can include things like verbal behavior. So what someone says could be threats, unusual speech, or swearing. I mean, those are pretty good signs that we need to maybe increase our distance, minimize what we say, slow down our words, relax our body posture, being on alert, but increasing our personal space from someone. I worked with a guy who would literally tell you, I'll knock your GD eyeballs out. And he would say it in a loud tone of voice. And that was a pretty good indicator that he would try to punch you next if you were close. So what do? We hear the threat, back off a little bit, step back, give space, listen, watch, clear the area. So I'm starting to like triage, like, okay, we have a threat. We need to make sure we provide support, but we increase our distance and try to clear the area. Sometimes there's just unusual behavior that's unexpected. And, could be any number of things from a person pacing back and forth rapidly to wringing their hands. Maybe they're talking to themselves, muttering under their breaths. I once worked with a woman whose primary precursor to a crisis was laughing, which was really odd because you'd hear this little laugh and think, oh, that's maybe a sweet thing. But staff who knew her well were like, oh, if you look in the plan, you'll see that that can be a common precursor to an aggressive act. So if we know that, then we know, something else we can look for. Another thing to do is look for patterns. So this could be changes in regular habits. If someone is eating more or less, sleeping more or less, if you see changes in their hygiene, especially lapses in self-care, those are things to make a note of so that other people are aware of it. In cases where there may be supported living homes or other care facilities, documenting so that that information moves with the person is so important so that other people know, like day shift to night shift and so on. Like I noticed she didn't really touch her dinner. We might check for a health issue first, and then we might just work down our list of potential concerns. Medication side effects, perhaps. Those are things to look for. So as the earliest stages of a crisis develop, that's when you want to have your support team ready, get them as ready as you can. Like we're seeing some of these concerning behaviors. I think we should have a conversation about how things are going. Have you had any other observations? So it's kind of a rally, get together, talk about whether we need to do something because we're seeing some of these signs. One of the things I used to use that I developed with a psychiatrist was just a depression checklist. And it was specific to an individual that we supported. And we would have a listing of, if 3 or more of certain types of behaviors occurred within a 2-day period, we call the support team. So if there was excessive sleeping, noted instances of crying, making comments about wanting to harm herself, we knew that if those types of behaviors were occurring, then we needed to get the word out, contact the support team, and discuss whether we needed to maybe contact the psychiatrist or physician to let them know these are the kinds of behaviors we've seen in the past before a psych hospitalization, and see if we could avoid a future one. So we're going to use that information based on the prior incidents if it's possible, right? If we aren't concerned about an imminent crisis, then we might be able to just provide support in an ongoing way in the person's place, right? Like wherever they are. It might even be just having additional staff available if it's a staffed facility, so that people are ready and able to, interact appropriately if needed. So there are a variety of things we can do here, but having a plan is going to be important. So there is a case study that we can talk about here, and it's linked through, but I don't believe you'll be able to click it. So I thought I would talk to you a little bit about Libby's case study, and I'm thinking about how to do this. There's a link here, and if I do click it, I think it's going to let me open and share it to you, but I'm going to have to probably stop share and reshare. I do this so often as a professor that I hope someone will let me know if it shows. Mark, does it show up? Okay, so I'm going to summarize this for you, but then ask you to go ahead and look at it yourselves once you get access to the material. So this is based on a case with some of the examples and information changed. But this is the case study of Libby, and she was a 36-year-old woman who lived in a 2-bedroom supported living home with another peer who had a moderate intellectual disability. She possessed high vocal verbal ability, so she was able to talk in full sentences. There were staff who worked in that home 24 hours a day to make sure that the care needs of the residents were met. She moved to a facility after her mother passed about 3 years ago. She and her mother, Libby and her mother, were very close and lived together her entire life. So her support team included her aunt, who was her legal conservator and who holds a durable power of attorney over medical and financial decisions. Her aunt would visit her once a month. She also had a board certified behavior analyst, a licensed mental health counselor, and a psychiatrist who actively participated in her care. We're looking at all these areas of her life and how we can pull together supports from these different angles, right? So regarding religion, she attended church services regularly, had a few friends that would sit with her each Sunday. She had several friends from church, and they would get together about once a week to play cards and talk. Looking at her leisure and preferences, we know that she enjoys playing card games with friends, gospel music, looking at magazines with pictures of gardens and animals. She enjoys housekeeping, so vacuuming and doing laundry, washing dishes by hand. She also liked sitting out on a porch swing with a crochet throw, and her housemate would sit with her. She liked watching birds on the feeders. So she had a diagnosis of autism, mild intellectual disability, and bipolar disorder 1 with the last marked phase of depression. She had high verbal abilities, able to communicate her wants and needs effectively. She took Depakote 500 milligrams a day to help manage the bipolar disorder. Labs were done quarterly to ensure her medication was at the appropriate level to maintain stability. And so regarding behavioral concerns, her behavior analyst and staff recorded instances of problem behavior or concerning behavior that indicated the possibility of her falling into a depressed phase. So we knew that these things would occur predictably a few times a year, typically coinciding with the passing of her mother in early April, and then again during the holidays around Thanksgiving and Christmas. So what would happen is that Libby would show increases in crying, withdrawing to her room, refusing to engage in some of those preferred activities, like going to church and meeting with friends. She would make repeated statements that she hates herself and everyone hates her. She would talk about the need to go away to the psych facility. And there was a history of her being hospitalized twice a year over the past 3 years following expressions of suicidal thoughts and attempts. At one point, she eloped from her home and lay down on the road saying she wanted to be hit by a car. So this is the time when you start to see these concerning behaviors occurring in Libby that you contact the support team. Support team is in agreement to work with her to develop a plan to support her if these kinds of problems emerge. So when the team gets together, they talk about a trauma-informed care plan and about how there are these key times of year that Libby tends to show the most depressed behavior, if you will. So the most depressed signs and symptoms. So what happens is that we encourage her to talk about her feelings only if she wants to, and plan maybe to do a little bird watching trip somewhere in early April to get out of town, away from maybe some of the typical things in her life. Um, Make sure that she engages in an advanced behavioral mental health directive. And we're going to talk about that, as well as a personal crisis plan. And what that is a way for Libby to tell us what it is that she wants to happen. So if you see, while stable, some of these signs of stress and you see some of these behavior changes, this is what I want to happen. I want to meet with people who love me and have them come to my house. I want distractions like fun movies or, being able to sit outside. So she identified some things that made her start to feel bad, talked about her wishes for treatment and care, and then what to do if she posed a risk of harm to herself. She also said she was afraid of being left alone in a room and doesn't like to go to the hospital. So in a meeting with her team, she said she was left in a room for weeks without seeing anyone. So although the staff in the hospital said this is not what actually happened, this was Libby's perception that she was just left alone for extended periods without seeing anyone. So what we noted from this is that she felt afraid and she was lonely and scared for being, away from people. She also said she found medication to be helpful if she's hospitalized for psychiatric stabilization. So here's some of the strategies that the team developed for this case. So staff observed her for signs of depression, especially times of the year when she's vulnerable, if we know that there are some peak times. For Libby, watching for some of these symptoms, including crying, withdrawing to her room, refusing to eat, refusing to engage in previously enjoyed leisure activities, even making statements like, I hate myself, everyone hates me, I want to die. I actually like write these things out exactly as they might be said. So people know, uh-oh, that's a flag. We need to react. Some strategies to try to prevent her from further escalating might include playing some soft gospel music in the house, because we know that's a preference, seeing if you can distract her with a card game, maybe going out to look at birds in the yard. Also, make absolutely sure the door chimes are installed and working properly on all exits to the home, because if there is a risk of her leaving and potentially getting out into the road, we need to make sure we have an alert, right? So during crisis, it's noted that if she engages in 3 or more of those pre-crisis behaviors in a day, her staff are going to get together, mobilize, talk about next steps, try to redirect, and then be sure that if she does try to leave the home, that we try to block her from leaving if at all possible. So, hey, I just noticed a new bird outside. You want to go look at that? See if you can do anything to try to redirect away. And then continue monitoring at least every 15 minutes. This is generally like an escalation plan that I would use. Instead of being in another room, kind of in the hallway, outside of a room, giving her some privacy, but still ready and able if needed. Making sure that we contact physicians if there are possible med changes needed, because sometimes a doctor will call in a special emergency medication if they deem it necessary. If lab work is needed, they may call that in, but that may require like a hospital visit to make sure that happens. If needed, if we're unable to stop her from escalating at that point, we may make a plan to call 911, start the process of a psychiatric hospital admission, and make sure that we take along the advanced behavioral mental health directives. You might even put those on like a thumb drive or have a printout that's ready to go. So this is like all the steps are there to try to detect it early, intervene early. But then if we find that we must do something to respond, by getting her seen in an ER, then those are the next steps that we'll take to keep her safe. So then the next important part of this is post-crisis, making sure that you meet with hospital staff before discharge, talk about any changes that have been made in medicines or treatment planning, and then follow-up appointments with the treatment team, psychiatrist, psychologist, behavior analyst, to talk about what to do. And I think one of the most valuable parts of that post-crisis is gathering a circle of support of stakeholders. Now, you may not get your physicians there, but other people like the staff, the family members, and Libby herself to get together and talk about what worked and what didn't work, and what we might try differently in the future. So that's one example of like trying to work through some possible problems to be ready to intervene at each level as needed, right? Let me go back to my slides. Looks like they might have closed in the background. That's not what I wanted to have happen. Okay, here we go. Back to Libby. So I urge you all to think, like, for anybody that you are supporting, what kind of strategies would you do at each level? When do you know that this behavior is escalating and it's time to respond at the earlier levels? And if a behavior escalation occurs, what to do next, right? I don't know if anybody here has experience with working through a case like this, but I'm guessing you've all had some observation that something was changing. Something about the way the person was responding to their environment, to you, was changing. Anybody care to drop something in the chat, like a little note, like you might put a few simple things that you've detected if you've worked with somebody who might be vulnerable to crisis? Just be really interested. I feel like every time Mark and I have done a talk like this and we interact with people like you, we learn so much too from your valuable insights. So if you have anything to share, like what's a sign that a person supported might show that indicate we need to convene the team. We need to start that process in motion. Does anybody care to plop something in the chat? Putting you on the spot here and I realize it.
Well, just so you know, I did put that invitation out there earlier and said if they do, just want to make sure that no
identifier
information in there. If they want to send it to me separately, I can actually de-identify it, or I can respond directly to them about those, and we'll go through it that way.
Right. And I think it's so important to note that everyone's experiences can be so unique. There are times that I have certainly had warning. In fact, there was a woman I worked with who was just a wonderful human being, just love her. She had been institutionalized most of her life since early childhood, and she was in her 40s. Just a sweet, kind person. And she had more like severe intellectual and cognitive delays. So she had a few sentences and statements that she would make. But it was very bizarre that the staff called the team and said, she's been up for 2 consecutive days without sleep. She's been wandering back and forth rapidly through the house. She will pick up an item, put it back down, pick up an item, put it back down, pick up an item, put it back down, like this repetitive kind of pattern. And eventually she would pick up the item and throw it and cry. And they thought, well, this is just not like her at all. So that's like a phone call of, we don't know what's happening, but this is very unlike her. What do we need to do to like figure out what support she needs? So the interesting thing is, like, we're trying to figure out what to do. We see that she hasn't slept in multiple nights, and somebody looks at her records and discovers she hasn't had her medication in 3 days. antipsychotic medication. So what I think we were seeing is somebody who is completely experiencing like that withdrawal from the medication for a long enough time period that we were seeing the psychotic disorder she was diagnosed with emerging to the surface. And the interesting thing is we communicated this to the crisis hospital because we knew at this point we can't just deal with this as staff and friends and loved ones. We're going to have to call for some additional help to get her stable again on her medication. And it could have been really unsafe to do anything else, right? We call the doctor. The doctor says, I think it's time to take her to, take her to the ER. So when she gets to the ER, the case manager comes in to talk to her. And it's bizarre because she's been, throwing things and crying and all this. And this is what happened. She got right close to her and said, I heard you're having a bad day. Like just a few feet from where she was sitting. Bam! She punched her right in the glasses. And it was almost like a cartoon because her glasses cracked in the middle and just one side fell off to one side and the other side fell off to the other side. And she was like, "Ah, I should have known better than to get that close. I can't believe I did that." I think everybody has an experience, that we think, oh, I wish I could rewind and do that better. We did get her under control again, like in terms of medication stabilization, and she recovered. But certainly it was like a warning to us, like make sure medications are administered, as planned and watch for possible changes, which started with the sleeplessness for 2 nights, 2 days and nights. That's not typical. So I don't know if anybody else has anything like that, but like I said, feel free to pop things in the chat. So activate pre-established plans to de-escalate behaviors. So first of all, documenting your observations. So for the young woman I just told you about, I'll call her Betty. Okay. So writing down, she didn't sleep for 2 nights in a row or 2 days in a row. We noticed she wasn't eating. We noticed she was pacing rapidly back and forth through the house. She was crying. These are not normal, and I say normal like in quotes, but typical types of behavior for her. Calling the team, sending out messages, hey, something is going on. This isn't typical for her. Then implementing the crisis plan. So that means convening the team, talking about what you see, doing a record review in this case, determining that medicine hasn't been given in a consistent way, then contacting the doctor to make sure, we're saying this is what we noticed, 3 days without medication. What can we do to support her? And then being able to make that determination, like this is going to require hospitalization. Using least restrictive strategies first. So in the case of Libby that I talked to you about earlier and showed on screen, trying to redirect, right? Playing gospel music, offering to pray with her because this is important to her, looking at birds outside. If you're concerned about going outside because of possible elopement, you could look through the window. I have done some really goofy things. I have a stepmother who passed recently of Alzheimer's, but she would try to escape from safe locations. And we would look out at squirrels and I'd make up funny stories about squirrels. You see that squirrel? He's waving his flag. Wonder who he's talking to over there. And, she would start to laugh. And it was just like diffuse, right? You could feel the tension reduce. Response blocking is important if you are trained and able to safely prevent injuries to someone. So in other words, if you're working with someone who maybe is hitting their head, having a soft cushion or something that you can place in the way to keep them from hurting themselves. In a case where someone is trying to harm you, it's very important to get training on how to prevent injuries to yourself. Sometimes the automatic responses that we think will be the best, or we may not even have time to think about them, it's just snap decision, are actually not the best. So if someone grabs a hold of your hair, our first instinct might be to like pull away, but most of the trainings will in fact tell you to like stabilize that hand, pressing it in instead of, pulling away. But only intervene to hold a person safely or response block if you've been trained in approved strategies. So like professional crisis management is one package training program that includes response blocking and also holds, restraints if needed. Safety care is another, and it's approved even for small children. And then Crisis Prevention Institute, which is Crisis Prevention Institute is they offer trainings. It's called CPI for short. I was a trainer for CPI for like 7 or 8 years. Similar to these others, a lot of de-escalation strategies to try to stop a developing crisis, all the way up to how to response block safely, how to get out of the way, how to talk to a person or establish contact with them, all the way through if a hold is needed. But it is so, so important to note that you should only use approved strategies. And the reason is that people that you're trained on and certified. Some people can get hurt without even realizing what they're doing, right? So certain types of holds can dislocate shoulders or hurt ribs or even cause problems with breathing. So if you are a person who's dealing with a lot of this type of crisis behavior that warrants intervention to keep you or the other person safe or other people safe, then you might look into PCM, safety care, or crisis prevention institute. So question time, quiz time. Where did my quiz word go? It's weird. So what are 2 important actions that need to be taken as soon as it seems like Libby is escalating into a serious crisis? So if you remember the example of Libby that I pulled up on screen and talked to you about, Libby is the one who would make threats to harm herself, had alterations in eating, and laid down in the road to be hit by a car. What are some things we would want to do? 2 important actions to take as soon as it seems she's escalating into a serious crisis. So A, make sure the doors have alarms activated. B, make sure Libby knows she's not alone. C, ask Libby if she wants to go somewhere. D, all of the above. Or do you think it's E, answers A and B? Let's see if you pop some of your thoughts into the chat, please. What are we seeing?
They're smashing the E button.
All right, good. And I'm going to ask you to elaborate. Why not C? Why would you maybe not want to go somewhere right now? If anybody will pop that in the chat, just for a little more discussion.
So you may want to reconsider taking her somewhere if she is escalated.
Absolutely. You've turned something that could be private and maybe smaller into a potentially risky public situation. Since I think everybody here in this chat, in this group right now, knows and loves and supports people who may exhibit, some kinds of behavioral challenges that are difficult, whether, in public or in private. It's so important, I think, I've always thought about it this way. Minimizing embarrassment to that person as a way of respecting their autonomy and personhood and being able to just say, okay, this is a moment that I need to offer support. I need to minimize any potential embarrassment or stigma to the person. That's what I'm thinking, right? With this question. So very good. Thank you for that. I think it's really tough to take somebody who's already really escalated somewhere else. Even a car ride is risky. I once worked with a guy who kicked a windshield out, and I didn't even know that was possible for a human to do that with their feet. Okay, so the next thing we're going to talk about is identifying strategies for intervention during a crisis through a trauma-informed lens. So it's important to know about past experiences with trauma so that we can help mitigate and avoid those kinds of instances in the future. So what we're going to do is talk about the impact of trauma first and some of the considerations we would use to develop strategies that are trauma informed. So first of all, like when we talk about trauma, the experience of trauma can include past, even, recent or distal events that may include physically, mentally, or even emotionally stressful events. In the professional field of supporting people with an intellectual developmental disability and a mental health condition, we're coming to believe most people we support who have experienced a crisis or may be vulnerable to crisis have some history of trauma. And increasingly, we're finding lots of professionals in different disciplines, including the one that I know and love, behavior analysis, are starting to look at treatment through a trauma-informed lens. So, in other words, we're not just focusing on the behavior of the moment. We want to look back at whether there may be some other triggers or events in that person's past that lead to a worsening or improving situation. How can we avoid re-traumatizing that person? So we're going to start this section just by focusing on trauma so that we can develop crisis interventions with a sensitivity to that, and we ultimately endeavor to avoid further traumatizing the people we're supporting through our attempts to help. So that's the real focus of this next section, is figuring out methods of de-escalating events that could become quite serious while also trying to prevent trauma to the individual. So trauma is so common in healthcare. And it can include behavioral and mental health care. So, people going to a psychiatric hospital or even going to a physician's office. It can include anyone, including those who have a dual diagnosis. It can include any diagnosis of the people that we support, right? So, many of the specialists that are trained to help may be unaware of intentional but potential harm. And these experiences of trauma are unique and they're individualized. It's important for us to be able to identify trauma sources, then the triggers related to trauma, and be able to craft some sensitive intervention strategies. Trauma can be short lived or have long lasting effects on a person's sense of well being. It may result in emotional responses, so things like crying, swearing, resisting help, or aggression. These may not be the typical types of behavior we would see in a person day to day. But if certain triggers are present in the person's environment, we may be more likely to see them. We may see avoidance of stressful situations, so people who just take off from safe environments. We may see misunderstanding or confusion about others' attempts to help. So just an approach or your body language may, instead of de-escalating, cause a little more escalated problem behavior that is just a misunderstanding. If you've ever watched a boxing match before, or any kind of fighting, MMA or whatever, I don't know if you've ever noticed that when they bring the opponents into the ring, they put them face to face, pretty close, face to face, glove to glove. It's a confrontational stance. And it's something to think about, that we don't want to do that. We generally are going to give more space and stand in a way that is non-confrontational, non-threatening. So there's a case example here, but I want to be mindful of time too, right? Mark, do we have till 6? Or I mean 6 your time? Is that correct? Okay. So I'll talk to you about an example, a trauma-informed care example of Keisha. So she's a 32-year-old woman who has moderate intellectual and developmental disabilities and schizophrenia. So for the most part, her schizophrenia is managed by a long-term psychiatrist who supported her for many years. She has a part-time job as a greeter in a grocery store. She lives with her mother and sister who love her. She has multiple friends and a rich community life. Sometimes Keisha would start to hear voices saying terrible things to her, so like telling her to harm herself, or she would see people staring at her with a look of disgust. No one else could see or hear them, and she would sometimes attempt to cut the voices out because she believed they were coming from somewhere under her skin, and this led to psychiatric hospitalizations in the past. So while the occurrence, the incidences have dramatically dropped from several times a year to maybe every few years, it remains an issue her treatment team is struggling with. So when she was hospitalized, she was left in a room by herself because she seemed extremely agitated when others were there. Following a recent psychiatric hospitalization and then during a person-centered planning meeting, she described how it was like no one could see me. I was crying so much, but no one could see me. I was so afraid to be alone. I kept feeling more and more scared. And her team learned from the meeting she needed someone she knew and felt safe with to stay close to her while she was in the hospital to provide safety and assurance when she heard and saw scary things. Her team developed a plan to ensure that if she were to be hospitalized, she would not be left alone. There would always be another person she trusted in the room or very nearby to reassure her she was safe and that no one was going to harm her. So her example, the example of Keisha describes how the hospital staff may have initially misunderstood her agitation, assuming that she wanted to be alone, when actually she wanted people near her and wanted that reassurance that someone she knew and felt safe with was present to help. Isolating in her case made things worse and further traumatized her. Okay, so I'm here to say that after going to psychiatric hospitals multiple times and facilities, there are times you can't dictate what they're going to do, right? Exactly. But if you're there at the time of intake and you have a connection with people, you can say, having someone available who checks in frequently is going to be so important if we can provide that. And like talk to them about how you've noted there is a better likelihood of de-escalating. It's important to communicate that and try to make that attempt to convey the information that we have. We're not always successful, but I think if we're able to communicate these things, you'll find more people are willing. They want to know. I haven't worked with anyone yet that a nurse or psychiatrist or other treating physician hasn't been like, what's going on? Like, what do you know? How can we help? Right? Because that's really what I think we're all about. So, trauma in the context of limited communication is especially difficult to assess. So, for individuals with dual diagnoses, we may have impaired communication or limited communication. A person diagnosed with an intellectual or developmental disability may not be able to use words to communicate if they're feeling uncomfortable or distressed. We may just see behavior, right? So, like, and I mentioned the woman who paced back and forth rapidly. She picked things up repeatedly, put them down, and then threw. Those are examples. Like, if she couldn't tell us, I don't feel right, something's wrong, she was going to show us. So, unease during stressful situations may present as unusual or problematic behavior, and it may be our only sort of warning sign. So, if you're planning for crisis, try to find information about their communication style and their preferences. Each person is going to express those discomforts differently. Those people who know the person best are going to be the ones who are most likely to be able to read the signs, being able to tell us, like, you may see whining or crying or holding an area of the body that's uncomfortable, making gestures, having a worried facial expression. We can see that too. You can tell if you're observing someone. So with limited communication, you might need to find ways to teach people to let you know using alternative or augmentative communication. So some examples are American Sign Language. Knowing a person's signs is very important. One of the issues with sign language is that not everybody is a sign language speaker, and it is a real language. So, when I've developed crisis plans in the past that include ASL, I have like photocopies of what the sign looks like in the person's book. And when you do training, you go through it. Like, help, hurt, pointing to the spot can help someone to understand. Otherwise, we've never lived in a better time for augmentative and alternative communication in terms of using devices to help communicate. Back, gosh, I don't want to say how many years ago, I had courses in AAC at Vanderbilt, and there were these devices, these talkers. Mark, you probably remember some of the Delta talkers or Salmons Preston's devices. They were something like $9,000 or $10,000 to get a device that was like a kind of like an overgrown calculator. I don't know if any of you out there have seen these like little computer devices, and they had little push buttons that would say like head hurt or, something to indicate what they needed. Now they have tablets with pro loquo to go added or on your phone. And it's just like using these talker devices. It'll give you little icons like the ones you see on screen, and you can push the button and it'll say what it is that the person is learning to communicate. Best time to do this is outside of crisis, teaching at other times, like how to press the buttons and get the output. PEX boards are low tech, but also very effective, having photos of what it is that needs to be communicated that a person can hand over or touch. Communication wallets. I used to develop communication wallets with PEX to go anywhere with the person in the community environment. So that's just so important to make sure we're helping manage appropriately and teaching. A note about post-traumatic stress effects. So a person and their team members may have a post-crisis trauma after an event. So this could include a severe behavioral or mental health incident, could include interaction with first responders, even if everything goes well. If you still have someone coming in to work, work with that situation, they're unknown to you, it could still be scary, right? Psychiatric hospitalization, physical restraint can be very stressful. I personally have never had one of those episodes that my heart rate wasn't escalated, that I wasn't really distressed and upset, because I don't want to ever have to control someone else's body unless it's absolutely necessary for their safety or the safety of others. Physical violence, a violent attack against a staff member or other community member is so very stressful for all of us. We don't want anyone to get hurt. Seclusion can be stressful. Medical interventions can be stressful. When some people go into the psych hospital, they quickly give them an injection in some cases to de-escalate, and there may be people who are very scared of getting injections after that. So this is what we need to know. Post-crisis trauma can look really similar to the types of behaviors that occurred before or during the crisis. So it's important to look for a loss of interest in activities they used to enjoy, changes in sleep and appetite after the event, fatigue or loss of energy, expressing excessive worry or fear. So we may have folks who are saying, I don't want to go to the hospital. Are they coming to get me? You may have people who are sort of replaying what they experienced. And those are the kinds of things to listen for and be ready to reassure and comfort. Everything's fine. You're safe. I'm here. You're here. Everything is fine. Let's talk about it if you need to. And by the way, even if someone says the person maybe doesn't understand what I'm saying, I'm going to continue to talk to them and offer support in all the ways that I know how. I'm going to be able to sit there, be close, and say, you're safe. It's okay. That's not happening right now. We're going to work through it. Difficulty sleeping, physical symptoms like racing heartbeat, shortness of breath, shaking, difficulty concentrating. If you find that people are kind of staring off, into the distance and not really interacting as much. And then irritability or anger. So in those cases where you see someone acting out again, you're going to be watching and keeping a closer eye on them to make sure that we're not seeing a renewed crisis event, but being ready. So it's so important to prevent trauma in mental and behavioral health care. And as care providers, we have a real responsibility to assess prior histories of exposure to traumatic events, work to avoid them, to identify factors to mitigate potential trauma. We want to plan ahead and be as proactive as possible. We want to plan to use the least restrictive procedures to de-escalate early. Reassure the person they're safe and cared for. That's so important. And then always incorporate that person's voice into the treatment planning process. If it's possible to get from them what it is they say. So in the example of the young woman who felt like she had been left alone for weeks without anyone talking to her, even if we know that's not really what happens because she had meals each day and people were checking in on her, that's her perception, and perception can be reality for people, right? I mean, I know this also from working with people with dementia, that sometimes, they'll tell you the sky is purple and you can see it's blue, but there's just no need to go, no, it's not. That's not true. That's not right. It's not important to correct. It's more important to support. Now you don't have to lie. Oh, yes, it's purple. But you can say, oh, I see it's a very pretty sky outside, right? Just some thoughts. So it's time for a little knowledge check and for you to participate in the chat, if you will. In your own words, can you describe one of the effects of trauma from crisis? It does not have to be specifically from this talk today, but something that you've noted in your own words that you could describe about effects of trauma from crisis. Bonus points if you say something that we could definitely describe, like in terms of what it looks like, what the person does, instead of just things that they might be thinking or feeling, but we might not necessarily know what to look for. What do you have? Mark, you got anything?
Oh, they are processing, but I was thinking with some of the folks I work with, one of the things afterwards was he would cry.
Mhm,
He would perseverate on the issue itself.
mhm.
But I had another one too that was very apologetic and
Oh,
would
yeah.
apologize for what had happened, and he didn't mean to hurt someone. He didn't mean to do this. Uh,
Yeah.
but I think it was kind of one of those signs of, yeah.
Mhm. Yeah, I've seen that too. Someone who says, I hurt my staff. I love my staff. I'm so sorry I did that. It's heartbreaking. And there are times that people may decide that's not a job that they want to continue to do. And I think that's valid too. If it's a traumatic event and you find that that's too stress inducing and it causes trauma to the staff, they may say that's not for them. And I've certainly worked with families too who are dealing with a loved one, child, whether adult or an actual child, and they may make decisions about providing more support or getting more support in the home, which is really important to be able to ask for as well. Seek out help. All right. Do we still have people out there, Mark?
Angie was saying too, about apologetic and crying, wanted to give a hug and kept saying, I'm sorry.
Mm.
Um, and also had a student who had a history of neglect.
Aw.
I had not enough food, or the days where she won't eat, and I can tell she's revisiting an earlier time. Becomes quiet, describes a bellyache. So
Aw.
at that point, they give her space and let her stay back to talk with us, and she visits with the social worker.
Hey, those are all really great examples. And something that one of you said about having a bellyache, I found that in children all the way through adults that they may describe it as like a stomach ache or a bellyache when they have feelings that are harder to express. And so that'd be something I would write down, sure. Thank you so much for sharing some thoughts. I think that's helpful to everyone. Thank you. Okay, so we have a little quick quiz with a case example. So this is about Genevieve. She has a dual diagnosis of mild intellectual disability and generalized anxiety disorder. And in the past, she's experienced episodes of panic in the community when in large crowds. She worked with her care team to design a plan to put in place the next time she's in a situation where she starts to notice shortness of breath, her heart racing, palms sweating. And that plan includes contacting a loved one immediately via text, sitting down, playing some calming music somewhere safe, waiting for someone to arrive at her location to help coach her as needed. So this plan is called, is it a safety plan? B, a general medical or care plan? C, an individualized support plan? Or D, a crisis plan? What do y'all think? Please pop some responses in the chat, if you will.
They're critically evaluating their choices.
Mhm. As you should. Because some of these are documents you may have heard the words for, like individualized support plan or ISP, right? But we have been talking about some things here that should be a hint.
They are all going with D.
There you go. D is a great answer. That's the crisis plan. Thank you so much. All right. Looking at the time. Okay. So, identifying strategies for intervention during crisis. The response stage is when an action is taken while someone's experiencing a crisis. So, a community based crisis continuum requires three main parts: someone to call, someone to respond, and a safe place. The responses to crisis are going to vary from person to person. So, who you call, who's going to respond, and where you go is going to vary. But it's important to articulate that in advance. It's customizable. You should have 24/7 access to interventions to de escalate, treat, and stabilize those behavior health needs while also trying to improve the functional and clinical outcomes for a person. Okay. Some therapeutic interventions for crisis de escalation and least restrictive strategies. The first thing is to reduce or remove demands and environmental stimuli. So people, noise, etc. This is when I think about triaging around a person. You can't remove everybody from an environment sometimes. It's not reasonable, it's not even feasible to expect. But we can try to minimize what we say. If we're providing a lot of instructions, we make it quieter, remove demands, try to clear a space if we can. I have been known to like go to a corner in Walmart and just sit there and chat with a person for a bit, or let them sit quietly with headphones on, or whatever it is that they need, right? If I've got a person who is showing signs of escalation, what I'm not going to keep doing is saying, you need to stop, you need to do this, you need to do that. I'm going to stop placing demands while I'm trying to troubleshoot. It's important to provide prompts to use calming strategies. So whether or not I tell a person to do some of the deep breathing exercises like box breathing that we talked about the last time, I may even do them myself and say, I really need a minute to take a few deep breaths. What do you think? Do you think that would help you as well? And mention those coping behaviors, even if you don't tell somebody what to do, but like demonstrating them to the extent that you can, trying to keep that environment as quiet, calming, and stress-free as possible. And again, worked in the community most of my career. Things are going to happen that are unpredictable, that you aren't necessarily prepared to control. We're going to learn from those situations and try to make the least intrusive approach the best one that we can implement. Using coping behaviors, if you know that a person has sensitivity to noise, offering headphones might be the way. I'm a little weird. I'll sometimes sing softly, sadly for that person, but try to kind of lighten things up a little bit. Using active listening is critical. So sometimes just being quiet, sitting next to someone or near someone and letting them vent is important. In cases where I've had individuals I supported we often developed like this sort of cognitive behavioral approach that, if you're faced with a stressful situation, you feel like, you're gonna pop, your face is red, you're trying not to punch somebody, you want to cuss them out. Here's your strategy. Ask for a brief break from work, take 5, go outside, get some fresh air. If you need to vent, call me. And I've had lots of clients over the years who would do this. They call and you're holding the phone out here because they just need to cuss and yell and rant and rave, but they got to a safe place. That's the goal. Where are you right now? I'm outside. I'm over by a tree in the yard. Okay. All right. What's going on? How are we going to solve this? Are there some things we could do to solve this? Have them pick something to try to implement and then agree to it and then work from there. But letting them just vent sometimes, expressing what they're feeling can be so important, so valuable. Very important to ensure safety. So if we know that a person is exhibiting some signs, some behaviors that are consistent with past crisis, that's when we want to make sure that things are locked up. If they're sharps or potentially unsafe, maybe we need to lock the kitchen, for instance. Increase our monitoring and proximity, make sure that we're standing closer, that we're ready to respond if needed. And also being ready to redirect to a preferred activity if we can. Distractions can be good. Putting something funny on TV, calling someone's attention to something else, just providing reassurance to the extent that we can. All right, it's a little quick quiz time. So what essential components are required during the crisis response stage? Is it A, someone to call, B, someone to respond, C, a safe place, or D, all of the above? What do you think? Pop it in the chat, please.
They were on that one. DD.
All right, way to go. You did it. So I mentioned this a little bit earlier about respecting personal space, and I can't tell you how important this is just as a de-escalation strategy. So this is just common sense, I think, quite often to just keep a safe distance and avoid hands-on interventions if you can. And so in CPI, they call this a supportive stance. What you're doing is you're going to stand at least a leg's length away from the person, because if they kick, you're a little farther away. Especially if a person is threatening aggression. Increase your distance. A supportive posture is when you're looking at the person or toward the person, but you're standing on kind of an angle. When I teach this live, I stand in that stance. It's kind of, you're ready, but you're not facing them like head to head or directly head on. You just kind of pivot so that like one of your legs is back, the other is a little bit more forward. And what it does is it allows you the opportunity to quickly scoot out of the way, like left, right, back, gives you a little more flexibility to be able to move. That's a supportive posture and a supportive stance. Make sure you also keep your hands in view and that you're not hiding them behind your back or even stuffing them in your pockets. In some cases, a person may interpret that as a potential threat. What does she have behind her back? What is she holding? Is she holding something in her pocket? So just hands relaxed at your sides, just like the picture you see here. But it gives you a little more time to sort of be able to react if you need to, keep engaging while remaining safe and creating an atmosphere where they feel safe. And I realize this takes practice. Again, I go back to doing training in crisis prevention like CPI or PCM or safety care to learn these kind of strategies to be ready should you need them. I've been able to avoid, knock wood, serious injuries over the years just by making sure that I'm ready to move if I need to and be able to get, clear a path if needed. Listening. So this means giving your full attention, listening and supporting. Part of creating that safe space is giving the gift of your full attention, being present without judgment, nodding to indicate that you understand and agree. Now, you don't have to agree if they're saying something that's not nice, but just being ready to reflect and hear what they're saying. I understand you're upset. Just being present with someone and listening is so important. And this is a good time to really think about avoiding any judgments about the person's behavior. And I've seen a person begin to de-escalate, but then a support person who may be well intended tries to give like corrective feedback right there in the moment. Like, you know better than that. You shouldn't hit people. You shouldn't threaten people. And it's, I understand the purpose of trying to educate, right? But this is not a great time. Generally, if someone is showing some signs of escalation, we're going to slow things down. We're not going to blame. We're not going to say things that sound threatening in any way, because it's so important that we keep an eye on like bringing that down, bringing that stress level down, the verbal behavior that we're hearing, maybe physical. It's not a good time to say, hey, you shouldn't do that. I've literally watched a person go back to fight mode when a person made a statement like that before. Next is to empathize, and this is just showing genuine concern and understanding without judgment. It can be a statement like, I'm so sorry that you're going through this. I hear you're having upsetting feelings, and I'm here to help you. It could be saying a lot less. It could just be a nod, like we talked about earlier. If the person says worrisome things, you can avoid agreement and try to still redirect. So, I understand you must feel scared or upset. Would you like me to put on some music for you, or offer a magazine, watch a show? Is there anything that might be helpful? If you know this from the past has been effective, it can be a great way to de-escalate. Keeping your eyes on it. Okay. Pausing and supporting. There's a lot here, but allowing the individual and yourself time to reflect and consider their choices. So this involves identifying strategies that have worked to calm the person in the past, considering their preferences from better days or times. I may not direct a person to do something, but if I know that a certain plushie is their favorite, I may pull it out and just offer it, put it next to them, or play soft music without even saying anything. Offering comforting items can be such an important way to like distract and redirect. I don't know if y'all have seen the weighted blanket craze, but a lot of people love them. I don't. I feel like I'm suffocating, but there are lots of folks who find comfort in a weighted blanket. Busy blankets are used quite often in elderly facilities, like care facilities or homes. They have like different little stimmy things, so like little buttons and zippers and things that they could fiddle with to sometimes calm and de-escalate. Offering to do typical activities or routines like washing dishes, doing puzzles, playing cards, painting nails. I've done all these kind of things before. Um, Sorting cutlery is comforting to some people, whatever it is. And sometimes I just start doing it. I don't even tell them they have to do anything, but just pulling it out and starting to do it. See if they come over and look. Distract by looking at a favorite figurine collection and talking about it. Oh, wow, I like this horse. This looks like a horse from a picture you had when you were a kid. Do you remember this? Distracting is so important. So if you know that holding someone's hand or offering them a hug is calming, then you might try it. I definitely think carefully about hugging someone who has made aggressive threats, because, you could get bonked, without possibly much warning. But if you know that holding someone's hand, touching their shoulder, if you know that a touch is soothing, then I try it. I would try it. It's important to acknowledge the impact of nonverbal communication. So our gestures, our facial expressions, and tone make a difference. If anybody here ever had a mom or a teacher or anybody who just commanded your attention with the look, the, squint your eyes, you know sometimes that's conveying a message. It doesn't even necessarily have to be said, you've had experience with it before. So it's important to try to keep your facial expression neutral. Your vocal tone should be neutral. And so this is another thing that's important. Even if you're a person who loves joking and sarcasm, an even tone is really important when a person is experiencing stress and maybe, engaging in crisis. And I used to teach about this, just thinking about how we communicate messages. I want you to think about the sentence, I didn't say you were stupid. Okay, I didn't say you were stupid. And now I want you to think about the message when I put emphasis on different words in the sentence. What do I mean when I say, I didn't say you were stupid? Anybody in the chat? What immediately came to your mind? I didn't say you were stupid. I didn't say you were stupid. What did you just communicate? I didn't say you were stupid. Different message, right? I didn't say you were stupid. Oh, but someone else was? Who were you talking about then? Right? I didn't say you were stupid. Uh-oh. Well, so you just don't like me then? Like you didn't say I was stupid, but you meant. So you see how just the way you communicate with someone can completely change the way your message is interpreted. Keep it neutral. Don't make fun of people or tease. Unless you find out that really is their love language. If that's something that helps them feel supported, to tell a joke. Yeah, I can't say never, but generally I try to keep it pretty even keel. Speak softly and calmly. If someone's getting loud, I get quieter. I was talking to a parent of a young child with disabilities. He was discussing tantrums and he goes, hey, so when she yells and tantrums, I yell louder. I scream at her, just copy what she does. Is that right? And I said, well, it would be really wrong of me to listen to you describe the situation and tell you what you're doing is wrong. Okay. It's inconsiderate. It would be unprofessional. What I will say is usually when people get louder, I get quieter. I give more space instead of getting louder, which may just escalate. Keeping the cadence of your words even kind of reflects on that note about sarcasm, the tone of your words, the cadence that you deliver them can send different messages. We read each other so well. By and large, we humans get really good at tuning into people's social behaviors and communication. So keeping calm in the face of a crisis can help make the person feel safer. I think that's so valuable. So it's knowledge check time. Into the chat, can you describe some of the strategies you can use or maybe have used during a crisis? Any strategies you can use during a crisis or have used? Some of the things we talked about here, something unique and special that you do. I have a cat in my lap. I don't know if you just heard a yell.
Less is more, less auditory and visual input, adjusting voice tone and volume.
Absolutely. Listening, empathizing, pausing and supporting. Thank you so much, everybody. Okay, so once the team has determined a crisis is imminent, it's time to assess that person's crisis plan and determine the best methods to respond. Use a calm, quiet voice to help de-escalate. Use previously successful approaches to create a safe space. Increase your proximity, but still monitor if there's a suspected risk of the individual injuring themselves. Use a supportive stance at least a leg's length away to minimize injuries or threats. And prepare to respond if properly trained only when absolutely necessary, using physical intervention strategies. Okay. All of these things become more challenging in a community environment, like in public. When I start to think about like how to become like a buffer between that person and the other people around. Calm, quiet, increase proximity, ask for space. Understand that the authorities may be called, and if they do come, it may be that it's an unusual situation, and their job is to eliminate the threat. So they may go in to try to interact with the person, give them some information if you have it. This person maybe has a diagnosis of autism, is nonverbal. He needs a little more space. If we can let him pace for a little bit, and he may make some sounds, he may even move his hands. If we can let him do that and then work through it, I will gladly approach and work to get him back into the car and home. Yeah, I've definitely done that. We also live in an area of amazing telehealth and technological monitoring. So telehealth services can be so helpful for remote crisis intervention and mental health support. And so I don't think about very many things being gifts from COVID-19. It's hard to be thankful for anything. But one thing that I think we did learn is that we could access more and more remote care. And telehealth is one of those areas that has really grown. There are mobile response teams in Florida that can help us access telehealth services and expand our services. There are people you can reach out to, get a call and reach a person on the other end of the line who will help guide you. The services are especially beneficial in rural areas, large counties, and regions with heavy traffic. Maybe you can't get safely to a hospital, or you don't feel like it's going to be a safe trip. So there is so much that you can do via telehealth and making calls, like, of course, to 988. This is our national crisis hotline. Most of you have probably heard about this. I think this was July 2024. This line opened up. So wherever you are, you can call or text 988, reach a person who will help you, or a person supported. There are crisis hotlines, mobile apps, other digital resources to get help. These are free, confidential, available in multiple languages based on categories of need. Of note, we on the team here recently discussed that if you call 988, there's no longer a press 3 to get access to LGBTQ specific supports. You would have to call a different number for that or go through the general crisis lines. It's just been cut from the program. In Florida, there are video phone services for ASL users and TTY services for people who are deaf or hard of hearing. And then there's another one where we'll talk about a little bit more, warm lines that are not quite a hotline, a 988. There are other warm lines to access support and services for people who may be experiencing a potential crisis. So you can, again, call 988 or text 988lifeline.org. You can go online and look it up. It connects callers to immediate crisis support and offers a variety of resources to coordinate care planning. So SAMHSA is this Substance Abuse and Mental Health Services Administration. There are so many resources on its webpage. If you check there, linked on this slide, but you can always write that down, check it later. Included, there are resources and information to help people living in different states, territories, and tribes with mental health, substance use disorders, all types of different services that may be needed. Suicide prevention, mental health crisis services are available 24/7 across the country. What else do I want to say about that? So it's an easy to remember single phone number, 988. There is a concept of the no wrong door approach. So what that means is all youth and families who have access to services, regardless of where they enter the system of care, whether they can pay or their diagnostic condition, they're going to be able to contact 988 and get a person to help. Now about warm lines. So I mentioned this briefly before. This is a connection for peer support. And in the state of Florida, there's a number here on the screen, 800-945-1355. There's also a link for the Peer Experience Peer Support Coalition of Florida. And so what a mental health warm line does is it connects callers to volunteers if they just need someone to talk to, someone to listen. It's operated through the state of Florida Department of Health, and it's staffed by trained volunteers or peers who are there to listen and provide support. I did notice that some of the hours may vary, and it's a good idea to know about this in advance, but you may have volunteers taking calls between 4 to 10 p.m. Eastern, 7 days a week, including holidays. There may be extended hours, so it's good to check in advance. You can also leave a message for a return call. And these volunteers are also trained to connect to other resources. So if you're needing help with like a housing situation, and they may connect you with like 211 or one of the other services to get help. There are teen and young adult helplines as well. So you can either call 800-950-6264 or text the word friend to 62640. This is the helpline at NAMI.org. There's a link here. And what it is a free nationwide peer support program where trained staff and volunteers or peers who have similar experiences may listen. It's available to self-advocates, family members, others in need of support. And what happens is if you contact via text or call, you contact the line, you get connected to a volunteer to offer support and resources, which is great for teens. The state of Florida is also covered with little dots. Just kidding. It's covered with these mobile response teams that are all over the state. So you can access 24/7 emergency behavioral health care anywhere in the state of Florida. You can certainly see that as you go to South Florida, it may be a little harder to find things that are close because I lived in Miami and I can tell you, yeah, it can, if you're kind of in that middle area, like Alligator Alley going across there, it would take a while to get from side to side, but there are some resources that are available listed there. You can get screenings and assessments, crisis de-escalation and stabilization, crisis counseling, safety or crisis plans, psychoeducation and care coordination through these mobile response teams. They're great resources that can help with diffusing and de-escalating mental health situations, preventing out-of-home placements, especially hospitalization, if you can contact and get them there. There are links as well to get to these different locations. We can share that with you. I think it's in the resources page. The Trevor Project is also a connection point for LGBTQ communities. So people can call 866-488-7386. They can text 678-678. They can go online to the trevorproject.org. If you are going through the website or a text, like you can, there's an immediate message that pops up that you can hit a quick escape to leave the site. Like if someone's peeking over your shoulder and you didn't want to come out or you didn't want to have it somebody reading your messages, there's a quick exit. And there are trained staff and volunteers that offer support. They connect callers to resources, and this is 24/7 year round. But Mark Harvey noted earlier that some of those budget cuts have also happened with the Trevor Project, so it's important to know about availability. They're asking for donations to keep it going, but I think the federal funding stream has been cut off. They're still running though. We just verified this right before our talks today, right? Okay, quick quiz time. Access to trained volunteers who are available via phone to listen if people need to talk and connect callers with resources during difficult times are examples of, is it A, 988 or their crisis hotlines, B, 911 or emergency services, C, community services, or is it D, warm line peer support? People to just talk to and connect during difficult times. What do you think, y'all? Warm lines, community services, 911 or 988. Pop it in the chat.
Noticing the pattern that answers are D's. So they are answering D's.
All right, you're correct. You are correct. That's great. So here's a little summary of what we've gone over today. So we talked about how to objectively describe and document a behavioral or mental health crisis, realizing, of course, you cannot control a person's behavior. You can't control a person, but you can't control how you respond to their behavior. And that may be the only thing and the most important thing that you can do. So, what we did in this module was cover how we could competently and empathetically address a crisis as it's occurring, and then being able to write about it, document it. We also talked about how to describe what a behavioral mental health crisis looks like and how to accurately document it. So important to do that. We talked about important considerations to de-escalate, right? So the importance of involving a team right away at the earliest signs that something is wrong, using strategies we've written down in a person's plan, exploring how important it is to consider the impact of trauma in a person's life when we're developing a crisis plan. We talked about the importance of listening, active listening to someone who's in crisis. So give them your full attention. We want to make sure that we offer empathy without judgment, even if they're saying things that seem rather unusual or possibly untrue. This isn't the time to say, well, that's not correct, or that's not really true, or I don't know why you would think that, right? Instead, we want to empathize and just be ready to provide support. We want to present a calm approach to the extent that's possible. You may be pounding, literally feeling your heart pounding in your chest, but presenting that image of calm, if you've ever heard of like the duck on the water, and it's just gliding along, but really the little feet are going like crazy underwater. That's us. We may be nervous, we may be a heightened state of arousal, but it's so important to like monitor our the tone of our voice, how loudly we're speaking, moving less, providing more distance, a calm body language. And of course, we reviewed some resources as an overview that are available in the state of Florida, including telehealth, the National 988 line, mobile response teams, and the Trevor Project. And so here are some of those resources for you. They will be provided in the PowerPoints that Dr. McGill is going to post and make available after this talk. The crisis text line, you can text hello to 741-741. It's available 24/7 throughout the US, serving anyone, any type of crisis. There is a veterans crisis line, 800-273-TALK. You press 1, or you can text that to 838-255 to access veteran supports, even if you're not registered with the VA or enrolled in VA healthcare. There is a national disaster distress helpline. You can call or text 800-985-5990. There is a national domestic violence hotline, 1-800-799-7233, or you can text love is to 22522. There's also a TTY link there for people who may be hard of hearing or deaf. National Child Abuse Hotline, 1-800-4A-CHILD. There's a National Sexual Assault Hotline, 1-800-656-HOPE. There's also an Elder Care Locator, 800-677-1116. And if you contact that, you'll be connected to like an area agency on aging and be able to access supports, including where memory disorder clinics are in the state of Florida, how to contact a geriatrician or psychologist or psychiatrist. So there are some resources you can use. And here are some of the references from the slides. If you're someone who likes to read, if you click on the orange links, they'll take you to those talks. But if you also need more help accessing, we're happy to provide the links to you. Okay. So if you've made it this far, we want to thank you for attending today. This is truly a work of love and care that we felt was so important to bring to others. And so congratulations, you completed Module 3. And no better way to end a big seminar like asking you to do a survey. This is a quick assessment to test your learning, to see if we've done our job today and gain your feedback on ways you think we might be able to improve the course. So you can scan that in, or perhaps Kristen, I see you just popped up, pop that in the chat.
Yep, it's in the
Yep.
chat now for everybody. The link is there. Thank you, Sheila. If you guys can just take a minute to
Thank
fill it
you.
out. And if you have any questions you want to ask, we do have about 19 minutes.
Left a little bit of change.
Yeah, we have some time left on the training, so let me know in the chat and I can unmute you and you feel free to ask your question. But I'll go ahead and stop recording for the purposes of the training.
Yes.